Good afternoon, everyone. We will start without losing time with the afternoon session. And I'm very delighted to introduce Mr. Simon Lumsdon. He's an international business leader in the field of med technology and fertility technology sector. And he works with fertility clinics in order to find a solution to implement innovative solution based on artificial intelligence and machine learning. Thank you.
Sorry. Okay. Well, thank you very much to the organisers for inviting me here. It's my first time in Lugano, and it's truly a beautiful city. I've been asked to speak on artificial intelligence and the clinical application. I have to say that I do have a conflict of interest in that I am employed by a company in this space that makes a commercial solution for artificial intelligence in fertility, and I also consult for another startup called Symbrio, which is unrelated to this, but is very interesting novel technology using blastocysts to model implantation. So, artificial intelligence is all around us in the world. I think it's hard to escape it, but within IVF, it's really been focused on the embryology lab. And if we do a small search in PubMed, we can see that for embryo selection and the use of artificial intelligence, there is over 460 results. If we move into companies, there's lots of different companies that are doing solutions for this. This is an example of one, which is called Fertility, that uses imaging to help select the best embryo. And I think we're probably all familiar with this technology. However, if we look at other applications within more of the clinical and the physician area, we can see that there's a lot less research in this. So a PubMed analysis just brings up 75 results for artificial intelligence and ovarian stimulation. And the question is why? Is it really needed? Is it useful? Is there an application for this? So we're going to look through 3 different areas of clinical work: initial dose, trigger timing, and ovulation timing, and see is artificial intelligence actually going to add any value to this and what's been done in this space so far. So let's look at initial dose. So if we go across different regions of the world, we can see here from this data, and this is our own data from Fertile AI, if we look at dosing in Europe, Middle East, and the US, we can see there is some variance. So in the number of days which patients are stimulated for, along with the amount of gonadotropin which is given, and then also the outcomes as well, so the number of oocytes which are collected. Now, of course, there could be many reasons for this. In the US, they're doing lots of freeze-all PGT. In Europe, this is less common. But I think the point remains is that there is some variance in protocol and practice. If we look at ways which have been described in the past to try and bring perhaps a level of standardization or models to initial dose, this is an early model from La Marca group, based not too far from here in Italy. And it was taking a few points, really, from the patient characteristics, the age, the AMH, and then giving a single recommended dose. This was published some time ago in 2012. And there's been a few models since then which have become a little bit more complex and interesting. This is from the Eugene group, where they use a linear regression model in order to take similar information. So the age, this time they're including BMI, history of fertility, AMH and AFC, in order to give this recommendation for a best dose. In terms of more modern models, and I think this is perhaps where the future of artificial intelligence should be going with physicians, is here is a model which we developed, which looks at a dose response curve. So the other models which were given gave one specific recommendation to the physician, which they can either accept or reject. This is doing lots of different analysis. So you can see here we have the number of oocytes that will be retrieved at 125, at 150, at 225, and so on. So instead of telling you as a clinician what you should be doing, it's giving you more information and more data for you to make the most informed decision that you want to proceed with the patient. We also did an analysis looking at the outcomes as well from well, the predicted outcomes, I should say. So this was a collaboration that we presented at ESHRA, collaboration with Merck Group, where we took 29 physicians and gave them 12 real-world cases with an initial starting dose, and then asked the physicians to predict how many oocytes they thought they would collect from this, and then match this to the AI and what the AI predicted, and then what the actual outcomes were. Of course, there's always going to be lots of variations and additional factors that, as clinicians, you can factor in and take into account that weren't given to those physicians. But you can see here that the algorithm is quite accurate, with a mean average error of just under 2. Moving on, let's look at the next application. So, trigger day. Now, this is not necessarily directly kind of about the trigger, but it's the consequence of when you trigger, I suppose. It's the number of OPUs that were in a large centre that we initially collaborated with. It's a huge centre. They do 9,000 egg collections. But you can see that the number of OPUs go up and down, up and down, up and down. And I've spoken to clinics around the world, and whether they're doing 9,000 collections, 900, 400, I think this pattern is recognizable in a lot of instances. There's been a few models already that have been developed in order to try and create something for a guidance on trigger. So Gerard Lettery out in Seattle was the first to describe this, and then there's 2 other commercial applications here, one from our group and then one from the A-Life group, which was authored by Eduardo Harrington out of US Fertility. And all of these products really are trying to do a similar thing. They're looking to optimize the oocyte yield and then bring in these workflow benefits. In the model that we described, we looked at the total number of follicles, estradiol, large follicles, and then the delta in the previous scan and blood test in order to predict how many oocytes you would have if you triggered today, tomorrow, or in 2 days' time. In order to test this analysis, we took 10,000 cycles. We then split them into material to train the algorithm, to validate the algorithm, and then test the algorithm. We then also looked particularly at ICSI cases, so we could measure the M2s rather than just the total number of oocytes. And the results of this were very encouraging for us. So in terms of if you were to look at our algorithm and then trigger today, the mean average error would be around 2.2. With a very strong R-squared scored of almost 0.7. If you trigger tomorrow, obviously the accuracy goes down a little bit, but still an R-squared of 0.62 in medicine is very respectable. And if you were to trigger in 2 days' time, of course, again, the accuracy goes down a little bit, but still is considered an accurate model. We then looked at how this actually compared retrospectively to what the physicians did in the data set we were analyzing. So we call concordant where the physician actually happened to trigger when our algorithm or when the AI algorithm said that you should be triggering to get the optimum number, and discordant when the physician triggered on a different day. And what we saw was that actually a surprisingly large number of the physicians in our initial study triggered on a day that the AI algorithm was saying was discordant. Now, all of these examples I'm going to show you come from programs that were working 7 days a week, so it wasn't an operational or logistical thing. It was maybe there were other factors at play, but yeah, and you can see the outcomes in terms of the total number of oocytes and usable embryos is significantly higher in the concordant group. So this was all from one center, so we thought, okay, well, how's this going to apply across other geographies and other clinics as well? So we collaborated with 3 IVF networks, some in the Middle East, in Israel, in Spain, and in the US as well, and looked at all different types of ovarian stimulation protocol. And the results were actually very similar. So what we saw was the number of discordant triggers was less. It was just over half. But in terms of the outcomes, the number of oocytes, M2s, and usable embryos was significantly higher in the concordant group. And just to say, I mean, this is retrospective data, so we take it with a pinch of salt, but it's a relatively large number, and we are doing 3 prospective studies at the moment. So we're excited to see the outcomes from those. We broke it down by region as well, and just to say that really there wasn't anything notable about this. They followed the trends from the market, so the US had a higher number, but apart from that, it was relatively consistent. What we also found was that in the data we looked at, most of the patients only had one optimal day to trigger, but then in just under half, there was 2 or 3 days. So we could use that flexibility in trigger day in order to smooth out those egg collections that we were looking at before. So this is the same clinic, and you can see before the dark blue line, that's the egg collections going up and down, up and down, up and down. But when we take into account that 48% of patients who have flexibility, we can then move them either a day earlier or a day later, and that almost halved the standard deviation in the number of egg collections that were being performed in that clinic. Some clinics want to work less weekends. I don't think there's any shame in that. This is a group that was working 7 days a week, but wanted to reduce for staffing reasons and quality of life. So again, before the balancing, they managed a relatively low amount of weekends without any egg collections, and then after, it was significantly higher. And although they were still working some weekends, actually the amount of collections they were doing on that weekend significantly reduced as well. So the guys could get home to watch the afternoon football game. So another area which we hear a lot about with scheduling and workflow is around natural modified cycles, which are increasing in popularity due to a lot of the papers which are coming out around hypertensive risks with medicated A.R.T cycles. And I was at the Best of ASRM in ESHRA earlier last year. There was a big debate around this. ASRM runs journal club debates. If you go to many congresses, it's a topic of conversation. I was with some physicians earlier in the week, and a lot of the conversation was around endometrial preparation for FETs and luteal support, and it still feels like there's a lot of work to be done to build consensus there. So in order to build this model, it's a smaller number of patients, but it's actually a very accurate model which was built because the quality of the data was very high. So we were looking at bringing the patients in every single day for bloods and scans, sometimes twice for a scan, in order to try and capture follicle rupture when we built the algorithm. So there's 2 ways for AI machines to build good data. One is just to have a lot of it, which is where we went with the trigger and initial dose, and all the other providers who do something similar have done that. For ovulation, the way that this algorithm was built was much more about the quality of the data. And it looks a little something like this in reality. So from an initial blood test, given on day 8 in an average length cycle, you can see that the system's saying that ovulation is likely to be after the 13th of November here. So the system will then give another indication that it wants a blood test on the 14th, so it'll tell you when to take your next blood. You can see on the right-hand side that the system has updated. It's split between 2 days. It doesn't know which day ovulation is going to be. It's either going to be the 16th or 17th. We then give it one more blood test, and it's fairly clear that it thinks it's going to be the 17th. So typically, just from 2.5 blood tests, we can quite accurately predict ovulation without actually any scans. Now, you probably would need to do a scan to look at endometrial thickness, but in terms of just predicting ovulation, this can be done from 2.5 blood tests. So in real life, how does this look? We did an analysis with a clinic that was closed on Sundays, but wanted to do as many natural cycles as possible. They had quite a high level of cancellations due to the patients that were landing on a Sunday for their transfer. They were happy to work a Saturday, but a Saturday couldn't be any more busy than a normal working day. They were happy to do triggers, but as long as the trigger was as close to ovulation as possible. So in terms of using AI to map this out, 93% of patients could be accommodated by this way. 6% of patients, either their transfer happened to land on a Sunday and we missed it, or they had premature ovulation. If we look at the workload across the week, you can see here on the Monday through to the Thursday, it's relatively stable. Friday is a really busy day for this clinic because in order to reduce the Sundays down to 0, they had to have one busy day. They didn't want it to be Saturday, so it had to be Friday. But the good thing from them, from a workload perspective, is that it's always going to be Friday. So every Friday is going to be a busy day. And then the amount of monitoring, like I said before, was roughly 2.5 for these FET patients. So at the start of the presentation, we asked the question, what is essential to implement? And I feel that's not something that I can actually answer, not being a clinician. I think that's probably for you guys to look at and ask yourselves, is this essential or not? But I think, can AI be helpful? Can it be a tool that can be used by doctors? Yeah, I think it certainly can. Can it possibly help standardize and maybe even lead to some improved outcomes? I think we need more data, but initial early data suggests possibly. And I think certainly with the scheduling constraints that we see a lot of clinics face, it can be a very useful tool. So I'd like to thank our collaborators and for you for giving me your attention. And yeah, I think we're taking questions at the end. Is that right? Perfect. Thank you.
Thank you very much indeed. We apologize. We had a little variation. And we will now move with the keynote lecture of the fourth session. And we will then come back with the scheduled agenda. So I would like to invite Dr. Caroppo. Dr. Caroppo serves as Associate Editor for Andrology, Editorial Board for Member for Fertility and Sterility, and the Asian Journal of Andrology, and is served as Associate Editor for Human Reproduction in the last 4 years. His topic today will be Innovation in the Field of Male Infertility, The Future Look Bright. Dr. Caroppo, thank you very much.
Thank you very much. So thank you to the organizer. And this lecture has been taught by Giovanni Colpi, who has asked me to search for novelty in the field of male infertility. And I have to say, with a Latin phrase, a famous Latin phrase, qui sivi, sed not in veni. So I searched for novelties, but I haven't found so much. So the bright future ahead in male infertility is just a dream. But I will focus on 3 papers. The first one dealing with the treatment of non-obstructive azoospermia by means of mRNA messenger transfer into the testes. The use of antibodies against the queen chorionic gonadotropin, who seems to have a potentiating effect on endogenous FSH and LH production. And a very enthusiastic editorial about the field of epigenetic applied to male infertility. So about the first paper, we know, thanks to the lectures already presented in the previous session, that NOA, non-obstructive azoospermia, may be due to some monogenic diseases in a minority of cases. But among patients with NOA, those with maturation arrest are those that have the highest percentage of monogenic disease causing NOA. So in these cases, if we will be able to overcome this genetic alteration, these likely pathogenic variants, we will be able to restore spermatogenesis in theory. Well, this has been tried in the mice model, and this is a paper published recently, published by NAS. These authors focused on a gene, the PDH2 gene, which is involved in the human pyruvate dehydrogenase activity, and it has been already identified in some NOA patients as no known cause of maturation arrest. And in this case, the transfer of PDH2 mRNA in PDH2 knockout mice was able to reach both germ cells and Sertoli cells, and obtain the resumption of meiosis, the complete restoration of spermatogenesis. So sperm could be retrieved by the seminiferous tubules, and healthy offspring could be obtained. The health of the offspring was confirmed by whole genome sequencing. So this is interesting, as this may be a promising tool for male infertility for non-obstructed azoospermia due to genetic origin. The same study was replicated further by this Chinese group, which used two other genes involved in maturation arrest, the MSH5 gene and the MAPS genes. And again, also in this study, the transfer of the mRNA of these genes in mice rendered azoospermic was able to restore both meiosis, spermatogenesis, and fertility. So my curiosity was to check whether there were other studies that employed some mechanism to restore spermatogenesis in NOA patients. And I have found that many studies have been sought to obtain the human-induced pluripotent stem cells to allow their maturation into pre-spermatogonia and spermatogonia, and then to transfer them to the testes. And the human-induced pluripotent stem cells may have the ability to be patient-specific, and they hold the potential to resume differentiation into any cellular lineage, although we don't know if they can be able to completely reconstitute the epigenetic reprogramming which is required. And indeed, about 10 years ago, this model has been successful in the mice model, since embryonic stem cells and induced pluripotent stem cells were cultured and then transferred into a recipient mice rendered azoospermic by generation antagonists. And this transfer was able to restore spermatogenesis, again to restore fertility. However, when the same experiment was replicated in the monkeys, it was really ineffective. The cells started to replicate the pre-spermatogonia features, but then arrested, and they were not able to go further. And what about humans? At present, the attempts at maturating patients' germ cells beyond the human primordial germ cell-like remain limited. There have been a lot of studies, and in some cases, these cells have retained some markers of the spermatogonial stem cells. However, the cultures do not last until the 80 days, and the maturity of cell is not able to be to use these cells to be transplanted and restore spermatogenesis. And indeed, the very latest ethics committee opinion of ISRM about this topic say that it's too early to replicate the success in mice studies into human studies because of many challenges that we have already seen, the low efficiency of the experimental procedure, the possible genetic and epigenetic abnormalities of these cells, the improper or improper imprinting, the need for human gonadal somatic cells to be used as a matrix, and then we don't know if these cells will resemble the complete epigenetic features of the human mature germ cells, and to know this, long-term studies of the offspring are needed, so this is completely unethical to do. Okay, we jump to the second study, which is very interesting. It comes from an experience in the field of animal ovulation induction. And briefly, we know that hormonal treatment of male infertility has been studied in the last 20 years, although most of studies were not randomized. And anyway, it seems that the treatment is successful in improving spermatogenesis and fertility, although the number of patients to be treated to obtain one more pregnancy is very high, from 10 to 11 patients to be treated for one additional pregnancy. Anyway, a Chinese study demonstrated that probably we are missing something, since the dosage of FSH usually employed in these studies is maybe not enough to stimulate spermatogenesis, since the use of 300 units of FSH on alternate days per 5 days was able to increase the sperm count and to significantly increase both spontaneous and A.R.T pregnancy rate. Therefore, this study may be interesting for the future of the hormonal treatment of male infertility. The authors found a strange behavior when they used the equine chorionic gonadotropins to induce ovulation induction. Equine gonadotropin chorionic gonadotropin was highly immunogenic, but the antibodies had the possibility to improve, to enhance the endogenous gonadotropin effect. Therefore, they first purified the antibody. They tested in vitro using the standard FSH biopsy experiments, and they found that, in effectly, these antibodies was able to bind to the FSH receptor and to the LH receptor, and to have a potentiating activity. Therefore, they developed an anti-human antibody using purified FSH administered to mice, and studied the effect of this novel antibody called CF12 on ovarian stimulation in vitro. And they found, briefly, that the use of this antibody was able to reduce the number of FSH ampoules needed to induce the production of cyclic MAP, both for FSH and LH or ACG. And for FSH, it was also able to increase the magnitude of the effect. And so they proved the effect of this antibody in vivo by stimulating the spermatogenesis of mice rendered azoospermic by GnRH antagonists. And they found that both the testis weight and the sperm count increased significantly after hormonal treatment, but only when the antibody was added. They completely restore spermatogenesis at the level before treatment. And interestingly, when they used it in vivo to induce ovulation in adult use, they found that they were this antibody potentiated the effect of endogenous gonadotropin. It induced an ovulation rate of 100%, which was very, very higher compared to the normal ovulation rate of 36%. So in conclusion, this antibody is able to interact with the receptor, induce the CAMP production, and reduce the number of the dosage needed to obtain ovulation and to obtain the response to FSH and LH treatment. And therefore, the authors believe that this may be a novel treatment, both for female and male infertility, for the future, hopefully. Okay, the third paper is an editorial appearing on Nature Reviews Urology about the field of epigenetic applied to male infertility. And what is enthusiastic, the enthusiastic statement about this is that the authors believe that the epigenetic is just a feature that may render spermatogenesis more malleable, so we can improve the spermatogenesis of the infertile patients by some treatments, including diet, including heat stress prevention, and so on. Because they believe that the sperm epigenome can be modulated in vivo. Well, I'm not so enthusiastic about this field because we know that epigenetic traits, once been inherited, are fixed and they can be transferred to the next generation, up to 10 generations. So, as brilliantly concluded by the authors, this challenge the views of epigenetic alteration being erased or reset at each generation. And this was already anticipated in 2016 when Michael Skinner, the best expert in the field, coined the term tertiary epimutation to explain that the epigenetic epimutation, once established and once escaping the epigenetic reprogramming occurring during the first phases of embryo development, they are fixed, they establish, and they are transferred like a genetic feature. And the possibility that epigenetic traits are passed to the next generation are demonstrated by several studies. Here I will show some studies about the ancestral exposure to DDT and the alteration in sperm epigenome in the offspring, which show very high percentage of neurodevelopmental diseases. And also the other studies showing that the fathers of babies, of children with autism, show a very clearly distinct sperm epigenome compared to fathers of healthy children. They have about 800 differently methylated regions compared to the fathers of healthy children. And epigenetic alteration have been also linked to the pathogenesis of male infertility, mostly of the male infertility causes that we deem idiopathic, may be epigenetic in origin, since, as we can see in this picture, epigenetic traits are located almost in all chromosomes following the ancestral exposures to environmental toxicants. And this is an old hypothesis that was coined and hypothesized by Skakebek and others already in 2000, and then in 2015 they furthermore stressed this concept by demonstrating that environmental exposures together with other environmental factors may lead to the complex phenomenon known as testicular dysgenesis syndrome that implies an increased percentage of cryptorchidism, hypospadia, shorter anogenital distance, decreased testosterone production, impaired spermatogenesis, increased testicular cancer. This phenomenon, which has been demonstrated in all around the world, and it cannot be explained elsewhere that by the ancestral exposure to toxicants, and it has been linked also to the link between male infertility and increased morbidity and early mortality, as already depicted this morning by Professor Gilman. Furthermore, the alteration in sperm epigenome have been found in men with infertility. Also, in men with infertility with idiopathic infertility, normal zoospermic patients with infertility. And now it's quite clear that epigenome abnormalities can even be predictive of IVF failure, and may identify probably patients that may be treated with hormonal treatment according to a study. And also epigenetic features are also important, since the baby can be transferred to the embryo and affect the genetic regulation, the first phases of embryonic development, although we don't know very well how this may happen, and we have not sufficient data to be really to confirm this. Okay, and finally, I would like to stress what Professor Gilman already said this morning, that the attention to the field of male infertility is very low, because as brilliantly exposed by this sociologist, the male is not felt as a fertility body, like unlike the female, the women, and therefore there are few funds for male infertility. So if we have few funds for male infertility, the future can't be so bright for male infertility. Thank you.
Thank you very much. So Dr. Caroppo is leaving soon, so I won't be able to answer questions later on. So if there are any questions from the floor.
Thank you, Ettore. I will be very happy and proud to transmit my epigenetics to my offspring. Of course, I'm willing to. The question is that the embryologist continues to tell me that every epigenetics is erased in the embryo. What is the answer to all of this? MicroRNA, they are certainly a mediator of the something between the genotype and the phenotype. In the middle, there are the microRNAs. They are certainly modulating it, but it is difficult to understand how that type of epigenetics is transmitted, inherited. How do we explain this divergent interpretation?
There are many proofs that the sperm epigenome affect the embryo development. There is already a study, I think in 2016 by Denom, who showed that normospermic patients who had good or bad IVF outcome and good or bad blastocyst quality, they had an altered epigenome, sperm epigenome, okay, when they had the poorer IVF outcome. And this was already confirmed by the mRNA expression, some key genes in the blastocysts, which were related to the expression of some microRNAs. Regarding the transmission of some traits, including the ancestral transmission, unfortunately, there are some traits of the sperm epigenome that escape reprogramming, along with some traits like imprinted genes which escape reprogramming. But the traits, the abnormal, the epigenetic marks of an ancestral exposure, unfortunately, they escape reprogramming.
Okay, thank you very much. So we'll now come back to the program and we will invite Dottoressa Di Luzio. Ah, okay, sorry.
Okay, then we switch to Dr. Romualdo Sciorio, reproductive biologist, has a very long experience in the field of IVF lab, and he will talk about a new model of interpretation of the quality of the blastocyst using AI model.
Thanks very much for the introduction. It's really a great pleasure to be here. It's a great honor. Thanks very much for the very kind invitation to Professor Colpi and to Marina. So today I'm going to talk a little bit AI and how we can use this to select blastocysts in the IVF laboratory. So I've been working as embryologist for about 30 years, but now I'm working with Vitrolife as a clinical scientist as support. So I don't have any. This is my disclosure. I mean, I'm employed from Vitrolife. So I will talk briefly about the embryo development, which is a topic that I particularly love. Then we'll move a little bit to the time lapse, and then. We'll talk a little bit about benefit of AI software, and actually, as Simon already talked, from the last couple of decades, we have different software from different company aiming to select the best sperm for injection, to select the best embryo for transfer, associated also with oocyte quality, for example, in donor cases, or as Simon said, to detect the best stimulation regime personalized. So I will focus a little bit more in the IDA score, which is proposed by Vitrolife, and to correlate it with the embryo implantation. So I like to start this talk with these pictures. This is a graph related to the scenario in Italy, but this is quite common in different other country. The last year, 2024, actually, we had less than this. We had about 370,000 baby born in Italy, and about 70,000 of these were through the IVF, so about 5%. And one of the topic, unfortunately, is the age. I mean, often a lady approaching or looking for the first pregnancy, they are over 30 or around 30, as you can see here, Italy, Spain, and Switzerland. That is over, and we know that is a natural factor. I mean, the germinal cells that are produced after a few weeks after fertilization, and therefore, at the time when a little baby girl is born, there is a specific number of germ cells that they are going to be used and ovulated in the entire fertile life. So that's, I mean, the excellent job done by Bob Edwards. It came just like, perfectly. Technology from the time of Bob Edwards, we can see from the pictures, like apart from black and white, but technology is completely changed, and nowadays we have a different approach technology based not solely in the AI and the embryo culture, but for stimulation, drug stimulation, clinical support, and so on. But altogether, pregnancy is still relatively low, it's around 30%. This is the last ASHRAE report published last year related to 2020. So this is the number of cycles, which is like 350,000. And the pregnancy, you can see here with the red mark, is around 25-30%. So it's quite low. Why this? Of course, what we do in vitro is completely different what we do in vivo. We try to do our best in the laboratory, but I mean, in one word, we have a dynamic scenario in vivo. In vitro, everything is static. And although we try to do the best to mimic, there are differences. There are differences, so there are some kind of stresses related to the physical and chemistry, changing pH, temperature, and so on. We know, in terms of culture media, different subground carbohydrate to grow embryo to the blastocyst stage. There are two main philosophies: the single-step media and the sequential step media. Vitrolife actually has produced recently a series with the antioxidant, so with the addition of cysteine, carnitine, and lipoic acid that will defend the gamete first and embryo later against the oxygen stress, which is the active oxygen species stress is one of the main one. But definitely the time lapse that came, in this case the embryoscope, has been one of the breakthrough in the last couple of decades. These are the three devices proposed by Vitrolife with different plays. All of these are medical devices, as it should be requested by European certification. And there are different benefits using a time lapse. So conditions which are more or less close to the natural. This is a paper by Alison Campbell showing that a good percentage of embryo, around 90% of the embryo after ICSI, the 2PN is appeared already between 16 and 19 hours. So having this, you don't have to rush, especially if you do the egg collection early in the morning, as was in Switzerland, for example. We used to do egg collection at 7 in the morning. So if you do insemination 3-4 hours later, you don't have to run in the lab 5-6 in the morning to do the PN. So this is one of the advantages. Different other advantages. This is a table showing many abnormal features that have been identified with the time lapse and then otherwise cannot be identified. And this is a summary on different papers published by different groups, show basically that with time lapse you increase embryo quality and blastocyst formation and therefore a cumulative pregnancy. This is a study showing, I mean, you can use time lapse for different research projects. For example, this is a kind of paper recently published showing that the cytoplasmic string can have a rule in embryo and embryo selection, as well as the collapse was identified first by the group of Meseguer, and we published as well a couple of papers on this subject. So the story of Vitrolife with the time lapse is more than a couple of decades ago. Some research started at the end of the last century. In 2008 was proposed the first time-lapse device, the ES. The 2010, the first baby was born, Kwan, through the culture in time-lapse. And then recently, in the last 4 or 5 years, Vitrolife has developed this IDA score, intelligent data analysis, that is correlated with the potential of blastocysts to implant and to give a pregnancy. Of course, you can see here there is a difference for an assessment which is based on one picture, so a static assessment, or a video, a movie that you have and you can stop and you can be concentrated on a different future that otherwise can be not identified. So from this static observation to the dynamic observation with the video and with the application of machine learning and then artificial intelligence, Vitrolife has developed this software, which is the IDA score, as I said, the intelligence data analysis. which is basically a number from 1 to 9.9. Higher is the number, high is the quality of the embryo and the capacity of the potential that this is going to implant. So this is consistent, is fully automatic, avoid the variability between embryologists. You don't need to include any data into the system, so no manual annotation, and it can be a support in your decision when you are decide which embryo you are going to transfer. So it works. Sorry. It works very easily. Basically, once you go into the software, you can put the details of infertility number of your patient, and the software produces a number, as you can see here, from this case 9.8. So basically, when the number is from 1 to 9.9, so high number like 8, 9, or more than that is associated with some high potential of implantation. And we have some study we are going to show now. So why to use this technology? Well, as I said, to avoid the variability between embryologists, this is one point, to have a consistency between the embryologist and the group of embryology. If you are a big lab of different clinic, they can have like a standardization between sides, and of course for training and so on. This is a paper published a few years back and shown, especially in the pictures on the right, as we can see here. I think this analysis was related to 47 different embryologists that done this study. As you can see, there is a kind of discrepancy in assessing the embryo, which are borderline embryo. Maybe it's not the case when there are excellent embryo, although even here there is some discrepancy. But for borderline embryo, is more evident. And then it's the assessment with AI is, of course, very, very quick in terms of time. Has been established that is 10 times quicker. And I'll come back with this paper at the end of the talk, which is was a randomized study which has been published on Nature Medicine last year. So how was developed this software? Was basically performed in different laboratories, 22 clinics, mainly in 3 different continents, so in the US, Europe, and Australia. More than 180,000 were the embryo analyzed. 33,000 known implantation data. So these data, they were basically the images produced from this data. They were used to train the score associated, of course, with the fetal art, with pregnancies. So it's very huge, let's say, data diversity. As you can see, different age, different transfer, because this was relatively related to day 2, day 3, and day 5 blastocysts, ICSI and IVF, frozen and fresh, and as the international data, so different patient as well. Yeah, this is the score, as I say, which is valid from day 2, day 3, and day 5. And basically, this is how this is just like a kind of concept. So going, the IDA score grows, and the fetal art grows. So if you have a high IDA score, you have high good quality embryo here, and the percentage that this will develop in a fetal art is higher. So in terms of validation, different studies you can see here then show the validation of this software. Two studies were internal study by Vitro. The other line they've been performed by different other group around the world. So the correlation here we can see, for example, the correlation with the clinical outcome. So the green bar, they are the high IDA score, and as you can see, the green bar result in high beta clinical pregnancy and ongoing pregnancy. In this case, again, this is a study by the group of Loredana Bori Marcus Mesagin in EV Valencia, and this is an association IDA score with implantation and live birth. So the blue bar are the blue bar are related to the implantation, and the light blue the live birth. And again, as you can see, when the IDA is higher, you have the high rate of pregnancy. This is similar, high IDA score. In this case, was performed in a vitrified blastocyst. So, of course, the assessment was done before, then you freeze your blastocyst, and then you worm according with the IDA score. This is another set of data from China. More than 7,000 embryo. This has been correlated with day 3 transfer. So day 3 transfer with association with the fetal A.R.T, and the correlation again is high IDA score, high percentage of pregnancy. Different associations have been done with morphology, with morphokinetic, and with haploidy, for example. Again, this is another study showing that the bar, this is correlated with the age as well. All the age here. The green bar is the high IDA score, and you have a high percentage of euploid embryo. This as well is similar. So basically here you can see high IDA score, and the pregnancy and live birth is high in terms of euploid blastocyst. This is basically similar. So again, high IDA score is correlated, increase with the high. So there is this correlation. Correlation also with the morphology. This is Gardner score, and you can see that the top quality embryo scored according with Gardner, Farina mice grade A or grade A for the trophectoderm are correlated with the high IDA score, and it was done on more than 1,000 cycles. Morphology on day 2 and morphology on day 3 as well. Good correlation with the 4 cell, less than 20% of fragment, and 8 cell on day 3. This is quite interesting as well, because they've been again correlated, the green bar, the I score in terms of IDA, with some specific time. This is time to expanded blastocyst, time to blastocyst, time to morula, and basically what has been reported in this study, that high IDA score correlate with some specific time that can be predictable of implantation. Here they've done the difference, the interval between start to cavity compaction and morula to start the blastulation, then blastulation to full expansion, and as well there is this correlation. This is a kind of trend that basically from the post-compaction, when the embryo starts to form the morula, and then from morula there is basically a cavity and expansion relatively in a short time, in a time which is between 8 and 10 hours. This should be the kind of best performance compared to embryo that we spend more time. And this is actually related with the exclusion. So basically, embryo that have high score on IDA, they have blastocysts with less cell excluded. This is as well, there is some other research, actually some of this is done by Giovanni Codici, which is here with us. If at the time of the compaction and morula, there are some cells that are excluded from the compaction, from the morula, that's been recognized like not really a good marker. So in this case, the IDA score correlated with the blastocysts, they have less excluded cells. In this case, the IDA score has been correlated with abnormal cleavage or direct cleavage related to less than 5 hours. So if an embryo in less than 5 hours goes from 2 to 5 cells, or have a direct cleavage from 1 to 3, which is recognized as a negative abnormal future, let's say, and there is inverse correlation with the IS score. So the IS score is a little bit higher when there is no direct cleavage. And this is the study I was telling before in terms of save time. This is a randomized study performed on 14 clinics, I think. And the two groups that were basically analyzed, and what I've seen have come, it was like a non-inferiority study. So basically what have been coming from this, that analysis from IDA score, and analysis like control group as a basically similar live birth and similar pregnancy. So with IDA score 46% pregnancy, with the control 40-48. So they are not different, but what is different is the time that you are going to assess the embryo, which is in this case 10 times quicker. There was a study performed on 1,000 patients. So finally, this is a paper produced by the IVI group analyzing 70,000 embryo, and basically they reported a shorter time to get a live birth, basically. So the point is that doing an assessment with regard on the IDA score, you have a faster, you reduce the time to get a live birth. And that's it. So to conclude, basically, the embryoscope family is give more or less good condition for embryo culture, almost virtually unchanged in terms of temperature, pH, oxygen, and so on. The IDA score reduce the variability between operators. This data has been produced on large support, large data from different units, and basically correlated with the morphology, morphokinetic, and euploid state. And thank you very much for your attention.
Sciorio, I think you have to leave. You have to leave, but do you have maybe 2 minutes for some questions?
I have some, yeah, 3:30, so there is time if you like for a discussion. I'll be here.
Okay.
I may take some water.
Okay, the next speaker will be Dottoressa Di Luzio. No, Dottoressa Di Luzio. She will never speak. So, okay. Okay. So we will carry on with the keynote lecture of the third section with Professor Piomboni. Professor Piomboni is full professor of Cell and Applied Biology at University of Science, and is president of the School of Medicine and Health Science and director of the Medical Assisted Reproduction Laboratory in the University of Siena. He's a member of the board of International PhD Program in Molecular Medicine, and she's the president of the Italian Society of Human Reproduction. Her topics today is endometrial receptivity, the role of diagnostic testing in reproductive success. Thank you very much.
Thank you. Good afternoon to everyone. I would like to thank Dr. Colpi for this kind invitation and to give me this very important, but I don't know how many I will be able to do for your upgrade on this topic. We go back to the female now, to the female situation, and we are speaking about the embryo implantation. The embryo implantation is a very difficult process, very complex process that can be divided in more stages. For the implantation, it needs a blastocyst, a competent blastocyst. The normal site of the implantation is in the posterior wall of the uterus, in the fundus, And the process starts around the 6 days after ovulation and will end around 11 or 12 days after. The implantation even starts with the apposition where the blastocysts attach there in some way, attach to the specific region where pinopods, these protuberance from the specific site of the uterus are formed, and then after this step the blastocyst cannot be displaced anymore. After that the blastocysts adhere to the surface and establish a more stable connection thanks to the adhesion molecules that expressed by the pinopods, expressed by the blastocyst, and many signaling factors included in the vesicles, also included in the vesicles, are exchanged between them. After that, the last step is the invasion before the full implantation. The invasion is due to the metalloproteinases, all the enzymes that are able to digest and different kind of proteinases that are able to digest the connection between cell and the tissue, allowing the invasion in order to establish one contact between the blastocyst and the maternal vascular system. Ma il puntatore funziona secondo voi? No. Ah, ecco, devo puntare esattamente qua. Perfetto, grazie. Okay, so the main actor of the human implantation are the endometrium, that must be receptive, the blastocyst that must be competent, and between them they must have a specific crosstalk to allow all the process that we describe. This process can happen only in a very narrow period of the menstrual cycle. This very narrow period is named implantation, window of implantation, and only in this period the uterine environment allow the crosstalk with the blastocyst. In the period that precedes the implantation window, the endometrium is pre-receptive, is the initial secretory phase. After that, the uterus became receptive during the mid-secretory phase, between 6 and 10 days after ovulation. After this period, the endometrium will be totally refractory to the blastocyst, non-receptive phase. So this period when the blastocyst can implant is specified by different activity by the cells. In the pre-receptive phase, you have a lot of molecules that, like glycocalyx, for example, carbohydrate that are present on the surface, and the junction are very strict. To become receptive, the epithelial and the blastocyst secrete molecules and enzymes that cut these glycocalyx, and then the epithelium develop pinopods. After that, in the stroma, the stromal fibroblast spontaneously became differentiated into a secretory epithelioid cells, and then the decidualization can promote the implantation, the invasion of the fetal trophoblast. So the crosstalk is very strict. A lot of molecules, a lot of signaling, a lot of pathway are activated in this moment, and this orchestra might song all together to allow the implantation. How many process are successful? Not so much. We know that about 30% of the implant fail. After that, 30% end in early pregnancy loss. After that, 15% end with a clinical miscarriage, and only 25% around will be successfully live birth. So it's a very imperfect process in some way. And then this is due to several factors, because if you add to the complex pathway, molecular pathway, the pathology that can affect this process, the pathology are very, very, a large number. Endometrial disease in some way, but also systemic disease, thyroid problem, immune problem, the genetic cause, as we know before. After that, the lifestyle, if you add the problem due to endocrine disruptor, lifestyle linked to alcohol, smoke, and other habits, or obesity, but also malnutrition can be deleterious for this process. And after that, if you perform a controlled ovarian hyperstimulation, also this process can negatively impact on the implantation. We just know this problem this morning, even if with different vision in some way, but we know that endometriosis and adenomyosis are the most frequent pathology at the endometrial level, and in most cases they are connected, they present together, and this is the big problem that also Professor Santilli said, reported this morning. So, as you can see, epidemiological and molecular alteration happens when this process go wrong. And endometriosis-related infertility in some way impact on all the steps, because the environment is not the same as in normal women. And embryo implantation is involved due to the presence of inflammation. It is an inflammatory environment that is characterized by an imbalance between pro-inflammatory and anti-inflammatory cytokine that act against, in some way, negatively interfere with the endometrial function. So interfere with the embryo adhesion, trophoblast invasion, desidualization, the tolerance from the mother to the fetus, vascularization. They have a very important role. So in the endometrium, all there's, from women with endometriosis, all these aspects are different. The same is for adenomyosis. Also adenomyosis can have a reduced implant, even more when connected to endometriosis. The problem are similar in some way, because several enzyme and inflammatory factor, growth factor, adhesion molecule are altered in their expression if we perform a molecular assay on this endometrium. If we add all the environmental injury that we encountered every day in our life, we have some other problem. As you can see, for example, bisphenol A, but also PCB and other molecules interfere with the signaling of progesterone and estrogen, because they are ADC, endocrine disruptor chemicals. So they influence negatively desidualization, adhesion, and implantation. The same is for controlled ovarian hyperstimulation. In this paper, they analyze two clusters of genes, and they demonstrate that at the window of implantation, they are different when we evaluate a natural cycle or an hyperstimulated cycle. So these can affect the biological status, the molecular status of the receptive endometrium. But the ovarian hyperstimulation negatively influence also the environmental where the oocyte develop, altering all the components, the granulosa cell, the follicular fluid, the cumulus cells, and also the oocyte, as well as the endometrium that I've just described. So this is the reason why, in many cases, all the embryo can be transferred after a frozen period. The segmentation is now a real option, or in many cases, not only when hyperstimulation protocol induce an over response from the patient. So to evaluate the endometrial status together with the usual procedure, we can use, you can use innovative strategy. Many strategies are now available that rely, in some cases, on the gene expression. This is the first one, I think, in 2013 was published this paper that evaluates the expression of the gene involved in the implantation, and the different color, red and blue, evaluate an up or down expression of gene that change the figure, the picture is different in all the steps, and depict the best moment to allow the blastocyst implantation. So, in this genetic test, a biopsy is evaluated by a central lab, and then the answer is released, and by this procedure, they report that the clinical pregnancy rate and the ongoing pregnancy rate are significantly increased from 19 to 60 and from 0 to 70%. Anyway, this is an invasive procedure, and the blastocyst transfer is not done in the same month when you perform the biopsy. So, in this case, many papers discuss the possibility that this ERA test is not so useful, and also that the results of the ERA test change from 1 month to the other. After that, the ERA test can be applied when we perform a frozen embryo transfer. Is it useful? No. The results of this systematic review meta-analysis said that the ERA test does not appear to improve the overall pregnancy rate when we apply in the fresh frozen cycle. After this, many others are reported. They compare their results with the ERA test, and they say, okay, the results are similar. For example, the BRIDI, this test include less gene respect to ERA test, more strictly related to the implantation window, but is very similar, the same procedure. Also, the AirMap test is very similar. All are made by different companies. And they said in this paper that by using AirMap test, we can increase in some way positive clinical pregnancy rate and also ongoing pregnancy rate. Anyway, when they compare a natural cycle with a stimulated cycle, they evaluate the a different gene expression in endometrial proliferation gene, maternal immune response associated to the embryo implantation. This is different test, Receptiva Dix, measure the BCL6, that is an inflammatory marker. If it is increased, no transfer. If it is low, good period to do the transfer, and they report a different pregnancy rate between the normal level of this marker and the decreased level of an increased level of this marker. And also in this case, the molecule is involved in the signaling that affect the progesterone receptor. A.R.T test, another similar test, but this is more focused on less, more specific biomarker, and also in this case they report that by using this test we can increase the pregnancy rate. After the evaluation of the gene expression, other tests can be used, for example, Emma and Alice. The names are very nice. Emma is endometrial microbiome metagenomic analysis, and Alice is related to the chronic endometritis. The test is combined and is able to analyze a lot of microorganisms included in the microbiome, together with the presence of features related to the chronic endometritis. They report a multicentric study that in women with repeated in success of pregnancy, and they show an ongoing pregnancy rate increased after the use of Emma and Alice, because they are evaluated, diagnosed, and then treated before the transfer. What is the limit? The limit is that this test does not assess the antibiotic resistance. That is not, it not exists a threshold value for the normal microbiota, and doesn't measure directly the endometrial receptivity. This is the reason why they after add also A.R.T test in this endometrio, Emma, Alice, and A.R.T test for all the people. This is a more holistic approach because more evaluation altogether, it can be preview a specific therapy before the embryo transfer. The reason of this, the amount of this test induce this analysis, SWOT analysis, that evaluate strength, opportunity, weakness, and threat. And they said that there is no any indication to offer to the infertile couple this kind of test. And the same is from A.R.T that published in Human Reproduction that there is not any evidence to recommend as a test to our couple. They are considered really hands-on. So what is the future? And I go to conclusion, I finish my time. The future can be a more holistic approach by the omics, by the study of extracellular vesicle, and by analyze in vitro model to better understand this very complicated process. When we talk about omic cascade, the omic cascade describes the entire flow, biological flow, in one organism, from the genome to the expression and to the product of this genome. So it would be useful to identify more specific biomarker, non-invasive biomarker. This is the best goal. For example, by using the follicular fluid or the uterine fluid, or even the span culture media from the embryo. This can be a real, more useful approach without less invasivity against the patient. The extracellular vesicles are very important in our lab. For example, we study a lot of this vesicle, and these vesicles are involved in all the situation, both physiological and pathological. They carry a lot of information, so they can be useful. And the other things that we are doing, but is not so important, I think, at this moment, is the in vitro modeling of the endometrium. We are trying to reconstruct a model that reassemble the human endometrium by using stromal and epithelial cells identified by this different color, by an endometrial biopsy, invasive, less invasive by the menstrual blood, and they have the same characteristics. So isolate the cell and reconstruct this kind of organoids. And the same can be done by using cell line that resemble the dynamic condition, because they are cultivated inside a continuous fluid refluxment in a dynamic system. So there are different approaches to measure, in conclusion, to measure endometrial receptivity. Their ability, their effectiveness is still well debated. The strategy of the omics is far from the clinical practice. Uterine, micro extracellular vesicle are well associated to the pathology and to the physiology of infertility. Organoids and or assembloids in static and dynamic condition can be a good model. They can recapitulate the uterine microenvironment to grow our knowledge about this very black box in our life. Thank you.
Thank you very much. So we will conclude the third session with the last speaker, Dottoressa Di Luzio. Dottoressa Di Luzio is an obstetrics and gynecology doctor with a higher specialist training in fetal ultrasound, and with a PhD in prenatal development and fetal therapy, and she actually works as a head of department of the ultrasound at next Fertility ProCrea. Her topics today, the pregnancies consequent to assisted reproductive technology. Thank you very much.
Thank you. I would like to thank the scientific board for this kind invitation and the chairman for this nice presentation. And I'm going to speak about the pregnancies consequent to A.R.T, and is a huge, really chapter of medicine. So it's not easy to just synthesize, but I tried to do my best. Does it work? Yes. Okay. So we are going to speak about the difficulty to have a dishomogeneous group in assisted reproduction techniques, and we are going to speak about all the different topics regarding chromosomal and genetic risk, and how to perform the different tests, which tests are more applicable in this group of patients. And we will speak about all the adverse maternal, fetal, and obstetric outcomes and the effect on the offspring health throughout life. And I just put a small part on informed consent and counseling in these couples, and also on the management of the assisted reproduction patients. The problem with the published studies are related to the fact that really is a very homogeneous group, and this is related to different techniques that are utilized for assisted reproduction techniques, to the cause of infertility. Female infertility, there are many causes, and male infertility too, and we have also couple infertility. So the big studies with a group of patients that are called assisted reproductive technique patients, in reality don't give really a true impression. of the situation, but at the same time, there are some strong evidence of some things that are in the last years were really clear. One of these things is that there is, when we speak about chromosomal and genetic anomalies, there is no higher prevalence of karyotype anomalies in ICSI or IVF pregnancy when we compare between them or when we compare with the spontaneous conceptions. And of course, when we adjust for maternal age risk. And there is a slight increase in risk of imprinting disorders in ICSI, but the relative risk is very low because we speak about one patient out of 12,000 patients. But it's also true that in the last years there were 7 million babies born with IVF and other assisted reproduction techniques. And so we have at least a good number of these patients with some syndrome that are macrosomic syndromes like Beckett-Wiedemann syndrome and Silver-Russell syndrome, or other syndrome that are called, one is Angelman and Prader-Willi syndrome. I was in the scientific board of the Beckett-Wiedemann Syndrome Association in Italy because I've done a few diagnoses during the year, so I was contacted by the parents that created this association. And there were a big group of patients in reality in Italy, and the most were really conceived with ICSI and assisted reproduction. And so it's a reality, and the patient must be informed also about that. And the first examination that we have to perform for the screening of fetal anomalies is the first semester screening. And this because the nuchal translucency measurement did not show any statistical difference between the study group in IVF and ICSI and when compared with control spontaneously conceived babies. And also in the first trimester period, we can do an early anomaly scan and also a heart evaluation. And when this anomaly scan is performed in expert hands, we have a detection rate for pathologists already at 12 weeks of more than 60%. This is also for heart problems. So it's really, really important to check the baby properly at 12 weeks. The biochemical screening that can be done has a higher risk of false positive rate. This is due to low papae, probably due to impairment placental development. And we can have also a low PLGF, and this is for preeclampsia screening, can give a risk, a little augmentation of the risk, and we also have to inform the patient about that. And somebody can say, so why we do the biochemical screening in this patient? In reality, it's not true for every patient that the results are abnormal, and we can have precious information about early placental dysfunction. The non-invasive prenatal test is the test that is really really loved by colleagues. But we have to think that in this particular group, the fetal fraction is really lower when we speak about IVF, and the test failure rate is higher, and this reaches 5% out of 2% in normal population. And this is extremely important if the patient would like to go through this kind of test, just do it at the right time. So wait up to 12 weeks, because if you do the test earlier, the risk of lack of result, of failure of the test is higher. And also, there is also a psychological important issue, because we have to know that after a positive test with a non-invasive prenatal test, we need to wait for an amniocentesis, because we can't really do the diagnostic test on chorionic villus sampling. So you have to imagine what it means for a patient who have a risk of Down syndrome with a non-invasive prenatal test that has to wait up to 16 weeks, 15 weeks. So at least 1 month before perform the test. It's really a hell. And so it's not right for the patient also. Many times the patient push to do the test earlier, but our really role is to explain things to the patient and to wait for this test. And it's interesting that the DNA fetal fraction is low both in fresh and frozen embryos when we compare with spontaneous conception, but it's particularly low in fresh one. So this is a case in which really the test must be dilated. And many patients, for the risk of chromosomal abnormalities, want to do, of course, a pre-implantation test. We have different pre-implantation tests, the PGT-A for a chromosomal abnormality, the M for monosomic genetic problems. There is another test. And the reality is that we don't have really a green light for these tests. We have a yellow light for the blastoma biopsy in terms of there is no evidence of damage, but there is no also a result that gives us the sureness about the fact that there is no harm to the baby. So more studies are needed, and more time is needed to be completely sure. We can suggest it to the patient with a good tranquility, but not with a complete security. Many times the patient think that if they are 36, 37, 40 years old with the PGT-A, they resolve the problem of a failure of implant, but in reality maternal age is related with failure of A.R.T techniques even after a normal embryoploidy, when the embryo is euploid. And also this must be explained to the patient. And it's not just maternal age that is important, but also advanced paternal age is associated with increased risk of spontaneous miscarriage, regardless the euploidy of the fetus. Another problem that was discussed in many papers is the risk of congenital fetal anomalies. There is an increased risk, and there are many reports, but it's very small. It's not really a big augmentation of the risk. The highest risk regard the cardiovascular defect. So it's really important that these fetuses are checked by an expert ultrasonographer, an expert doctor involved in maternal fetal medicine in order to check the heart properly, because this is the higher risk. And we have also many papers that think that there is not really a complete correlation with this augmentation of problems related just with the techniques of assisted reproduction, but we can have also the possibility that there is already a bad outcome associated with the underlying diagnosis and the problem that brought the patient to infertility. And this is true for many different pathologies. In particular, is true for endometriosis, for adenomyosis, for the presence of fibroids, for polycystic syndrome, for obesity, and for advanced maternal age. So regardless the techniques used, these are pregnancy at high risk, and they must be really followed with a multidisciplinary team in many cases. This is I just put some papers, so you will have the slides, and so you can go through the literature early. And this is also on endometriosis. And there is, of course, there are some other risks related with the assisted reproduction technique. There is an increased risk of diabetes mellitus, but we don't know really if it's related just with the assisted reproduction techniques, probably there is already a low-grade inflammation, already an insulin resistance, sometimes that were not checked before, so now it's important to check for these problems before starting the therapies. And there is an increased risk for sure for preterm birth. And in particular, it's very interesting to see that this is true for both the pregnancy following frozen embryo transfer, but also after fresh embryo transfer. The difference between the two groups is that the patient that are pregnancies that comes after a frozen embryo transfer have also an associated risk of hypertension. And in the patient with fresh embryo transfers, this risk is not present normally, but the risk of preterm birth is present in both groups. And this is another paper about that. But also we have to think also on congenital uterine malformation that sometimes are not diagnosed properly or are not treated properly, and they can be related also with premature birth. And in particular, is increasing the interest on T-shaped uterus because there is really evidence, there are many papers in single centers that regardless the indication of the Society of Fertility, sterility are having a very good result after the metroplastic treatment of these cases. The risk of preeclampsia is well known and is particularly true in oocyte donation, but in all the groups. The risk of cervical incompetence is increasing in different previous pathologies like polycystic ovarian syndrome, and increased BMI, the presence of a low MH, and also is related with the frequency of hysteroscopic operation and with the presence of congenital uterine defects of the prior pregnancies and treatment. And it's increased also with the fresh embryo transfer, and this seems to be related with the elevated androstenedione levels. This is a very interesting study that, because it is a review of the literature, and you can have a lot of papers reported on all the complications, starting from pregnancy complication to placenta outcomes to perinatal outcome, congenital anomalies, childhood, and the particular attention was reserved to neurodevelopmental health in the offsprings, and also in problems that can appear during the adolescence period and in the young adults. The follow-up of the patient is up to 40 years old because, of course, the technique started in 78. And at the moment, really, there are some things that are very clear. It looks like the neurodevelopmental problems are related more with the presence of twin pregnancies and preterm birth. And so, since the transferal of a single embryos was suggested, the risk seems really lower. And in all this situation, the paper that was studying the placenta in a long and very big number of patients, they concluded that probably the placental contribution is the most important in terms of complication in pregnancy related to assisted reproduction technique. And it's also interesting the fact that it's very difficult to give really to understand which is the mechanism and the technique that is related to the problems presented, because of course we have parental factors, we have in the last 40 years the environment has changed so much, and we have many insults on epigenetic problems, and so the techniques are changed, so the studies really don't give us for sure there's some indication, but as I told you before, there are some topics that were defined and cleared. And okay, obstetric and neonatal risk are increased by different infertility-related diagnoses, as I told you, and some complication, in particular placental problems, are for sure increased by A.R.T treatment. And ultrasound diagnosis of placental umbilical cord, it showed that there is not just a problem in placentation, but also in a cord insertion. There is an augmentation of abnormal cord insertion, and there is in particular an augmentation also in velamentous cord insertion, and this can be related with the problems. A review of over 6 million singleton pregnancy find increased risk of placental anomalies. That are the things that we can really study very well during pregnancy to check the patient that are at highest risk. As I told you, there is an increased risk of velamentous cord insertion. I was studying the cord of all my life, 30 years, since 1996. And so I did some study on the umbilical cord. This is an abstract that I presented at the World Meeting of Ultrasound in Rome in 2016. And I was curious to see if it was reproducible and how much time it was necessary to check the cord insertion and also the incidence of abnormal cord insertion in a normal consecutive population. And in this study, as you can see, in reality, the study in the first trimester is really easy with the color Doppler to check for cord insertion. I was doing this research with the junior operators I had with me, and the time necessary to do the measurement was roughly of 9 seconds, from 3 to 30 seconds at most. So it's something that I think we have to include in our clinical practice. And the risk to find an abnormal cord insertion in normal population is low, even if it's increasing in the last years because of environmental problems. But normally you have just 1% at most of velamentous insertion and about 4% of abnormal cord insertion. And this is a population that must be checked with more attention, at least with the Doppler at 20 weeks to check for risk of preeclampsia and risk of abnormal growth. And another problem that was surely correlated with IVF and with ICSI is congenital heart defects, and that is increased, so this patient must go through an ultrasound, a proper ultrasound at 21 weeks at least for checking the fetal heart. And what is interesting is that in another study that I published also in the World Meeting in Rome, I found I was in that period at Niguarda Hospital, and I was working with the fetuses with the heart disease because we had the prenatal cardiologist and also the surgical. And I found a very strict correlation between the abnormally inserted cord, abnormality in the placenta, and the presence of heart problems in the fetus. In particular, in the population with heart defect, the incidence of umbilical cord, anomalous umbilical cord insertion reached up to 20%, and in the conotroncal anomalies was up to 30%. So this can be a very easy screening test to check for patient at risk of cardiac anomalies. In conclusion, IVF is overall safe, but is not risk-free. Absolute risk remains low despite relative increases. Most excess risks are reduced with the only set single embryo transfer. So this is mandatory in many countries now, but not in every country. We have to put maybe a maternal age limit because of previous problems and pathology in the mothers. And for sure, women with comorbidities and oocyte donation are of special concern. And we need to inform the patient. And the information is done from with the preconceptional counseling. The preconceptional counseling must include a genetic counseling and the psychological counseling. This is important because to navigate the stressful procedure, the patient needs and help. And, but the counseling, even if it's important, doesn't substitute the informed consent. That is difficult to inform really the patient. So the first step is the counseling, but then there is the necessity to have an informed consent. The take-home messages, these are the things that we already spoke about, but I want to speak about risk and management. Fetal malformation and fetal heart anomalies that are increased, request a referral anomaly scan with A.R.T scan starting at 12 weeks. Placental anomalies, placental dysfunction, the risk of fetal growth impairment, the umbilical cord anomalies, increased risk of preeclampsia must be checked with serial growth assessment, including placental Doppler, fetoplacental Doppler, fetal Doppler, and also monitoring of fetal heart adaptation in the latest part of the pregnancy, and must be done in expert hands. This is not something we have to do in every patient. We need to screen the patient at the first trimester. In the second trimester, select a group of patients that are at risk because of a personal history, and then send this patient to a fetomaternal doctor able to do all this kind of assessment. Of course, the increased risk of premature birth must be checked by measurement of cervical length. And it's also important to think about intrapartum risk and to perform Doppler estimation, fetal weight, cerebroplacental ratio, umbilical cerebral ratio, just in order to choose the correct timing of delivery and the correct mode of delivery. And the last take-home message is obstetric and neonatal outcomes in patients undergoing A.R.T also depend on adequate pregnancy management, and is secondary to a precision medicine approach. So we can't have a group of patients, we have a single patient with a single problem. And we can't avoid every problem, but we have to try to manage it in the best possible way. Thank you.
Thank you, Luisa. We have a few minutes for the questions, comment from the audience. Please. Thank you, Gideon.
I have two questions for you. The first one is, what is the reason why the fetal fraction of DNA in the maternal circulation is lower? Is that linked with the placental size?
Yes, it's probably linked to early impairment of placental formation. So it's also an interesting report. So if we see at 12 weeks a very low placental fraction, we can think about a possible impairment in that placenta, and it's reported.
The second one is a tricky one. You said in some slides ago that we should perhaps limit the maternal age, especially when we think of oocyte donation. What would you recommend, and why?
Of course, I am really fond of precise medicine and personalized medicine. So we know that biological age and anographic age are not always coincident in patients. So, of course, there is also medical support. But there are discussions after 46, 47 years because of risk, and in particular for the risk related with oocyte donation and the risk of preeclampsia, and in advanced maternal age, the risk may be even worse. But there is a discussion. There are a group of doctors that think that their stopper age is 46, 47 at most, and they wouldn't go ahead. Okay.
Our questions? Maybe I have a question for Professor Piomboni. a very practical question. If you have a young couple, a young patient, after two failed embryo transfer with two blastocysts without pregnancy, and the patient asks you, I would like to do an ERA test, I would like to perform a microbiome testing, what will be your answer?
As you can see by the ESHRE guideline, and that suggested that it is not so useful to add other investigation. Anyway, if you know better the situation of the endometrium, this can help this patient to reach a pregnancy. We know that also that the embryo counterpart has is highly important. So it's not so easy in a young women. We can do more to understand why this problem happens. I think also it would be useful to investigate the embryo counterpart. The only investigation that we can do after the morphological development, thanks to the AI applied to the embryoscope, can be the PGT, that is not recommended in young women. But if we have two failure, we can think that something is wrong. And the male partner must be also well investigated. As discussed before, the male partner is not so fully considered. We do some investigation in the male partner in our lab, for example, fish analysis for X, Y, and 18 chromosome. We do DNA fragmentation. In specific case, also transmission electron microscopy. If something must be useful to deep the knowledge about the morphology of the sperm. After that, all the things must be considered. For example, the frozen cycle, the transfer of the embryo in a frozen cycle, because in the fresh cycle, the endometrium is not so receptive, even if all the other, I don't know, progesterone level, or I don't know what is your routine in the clinic, is good. This can be a problem in some patients. So, create or perform the embryo transfer in the natural cycle can help to have a more physiological situation. Because I think at the endometrial level, the answer is different from one patient to the other, also among a young patient.
Thank you.
I don't have the right answer.
If you don't have any question, I think it's time for the break. See we in 15 minutes. What? Exactly 15 minutes. Thank you.
I wish I could be the girl at his side, the one who has taken my place. Can everyone see what I'm trying to hide? Isn't it written all over my face? Well, I guess that you know what extremes I have gone to prove that I didn't care. You were so anxious to meet the dream that I've hung on to.